Instrumental delivery, one of the dying art in modern obstetric practice. Sure, use of instrumental delivery is markedly decreased in the last 2 decades due to increased rate of cesarean section and more safety due to of cesarean section due to development of anesthesia and antibiotic and surgical technique. And there is general trend towards cesarean section due to increase its safety and increased medical legal aspect as regard using of instrumental delivery. So in this lecture, we discuss briefly what the role of the instrumental delivery in modern obstetric indication, maternal disease, like rheumatic heart disease to cut short second stage and certain respiratory disease, where bearing down is unfavorable for the mother or partially contraindicated. Maternal distress due to prolonged labor, fetal distress, especially in second stage, prolonged second stage if it exceeds 2 hours in primary or 1 hour in multi-bara, exceeding 1 hour if we used epidural analgesia. The recent recommendation now try to return to instrumental delivery to increase the rate of cesarean section. What is the relation between epidural anesthesia and instrumental delivery? Epidural analgesia is increased used nowadays. The problem with epidural analgesia, it decrease reflex bearing down or reflex bearing down and spontaneous lactation in second stage. So it's a prolonged second stage. Say it may need to use instrumental delivery in conjunction with epidural analgesia. Forceps. The discovery or secret of forceps begin with William Chamberlain in 16th century. He practiced forceps delivery. He first to discover or innovate this instrument. He practiced forceps delivery as a family secret in Southampton and was kept as family secret for more than 4 generations, over 100 years. There is no other person outside this family know the forceps. Then the secret became too widespread in European countries. This is the Wrigley forceps, one of the used nowadays, or outlet forceps, which has pelvic curve. This is Simpson forceps has no pelvic curve. This is Weber forceps. Sorry, this is the Wrigley forceps and how to apply it to the fetal head. This is the Weber forceps and has perineal curve here and applied to after coming head of the breech. So you need perineal curve. Function. Mainly traction. This is the most important function, and traction should not be excessive, just with the wrist and elbow, not using another joint. Compression effect. This is the minimum. When properly applied, should not be more than necessary to close the head. Rotation of the head. In modern obstetrics, there is no need to rotation by forceps, mainly traction. Protective to the fetal head, especially in preterm labor. Lastly, during cesarean section to facilitate delivery of the head. Classification of forceps operation. Low or outlet forceps. Here is the head is completely rotated and sagittal suture in completely anteroposterior diameter and nearly station +3 or head on the perineum, and the application of forceps nearly safe at this stage. Mid forceps light when head is engaged 0 or +1, and we need excessive rotation, so it's not so safe. High forceps, it's obsolete or condominant to apply forceps on non-engaged head. This outlet forceps, fetal scalp should be visible without separating the vulva. Sagittal suture, as we say, is anteroposterior diameter, fetal head on the perineum station +3. Low forceps, sometimes we use forceps in a low Forceps application. Here the stations plus 2 rotation minimal 30 degree, 20 degree, not exceeding 45 degree. Mid forceps and high forceps nowadays not used. An application, how to apply either your guidance is the head, and so this is cephalic application. You look for the head and apply the forceps in both sides of the head. Or pelvic application, you take lateral pelvic wall, your guidance to apply forceps one in the right and one in the left. So when the sagittal suture is completely anteroposterior diameter in outlet forceps, you can apply pelvic application. Pelvic is the same as cephalic, because if you apply it laterally, you the same as the lateral aspect of the head, so the trauma or complication either to the mother or the fetus is minimal. What about vacuum or Ventouse? The introduction of Ventouse was in 20th century in 1950 years. First was a stainless steel cup, then replaced by a silicone or soft cup or plastic cup. Sure, the metal cup is more powerful and less failure rate, but a soft cup less traumatic to the fetus and less complication. This is how to apply Ventouse for vacuum. Here should be applied on occiput posterior or near occiput, an occiput anterior position, but near occiput, away from anterior fontanelle to decrease complication or intracranial hemorrhage. Traction should be downward then forward with the same axis of delivery of the head. In 1998, Food and Drug Administration released an advisory letter to alert individuals who use vacuum to inform that their device may cause serious or fatal complication. So it should be used with specific indication. The operator should be aware of indication, contraindication, and precaution. The trial should not exceed 3 trials. If failed 3 trials, you should move toward either cesarean section or forceps, and prefer to do cesarean section. The operator should follow manufacturer's recommendation. Rocking movement is completely contraindicated, and unit test should be attend this delivery. What is the advantage of the Ventouse over forceps? Sure, less maternal complication, need less experience, and learning curve is easier than forceps, not occupying space between the head and lateral pelvic wall, and you just track, not rotate. Auto rotation can occur during traction. The head take its natural pathway. She rotate itself. You didn't surround the head, so the rotation can occur. But in forceps, you surround the head and you only control the rotation. Disadvantage, sure, more fetal complication, not suitable for face presentation, preterm, or dead fetus. Complication mostly occur due to faulty technique rather than instrument, injury, vaginal laceration, or injuries of bladder, or extended episiotomy, or postpartum hemorrhage due to trauma, or atonic uterus due to prolonged labor, not due to vacuum or Ventouse, or due to anesthesia. Shock due to prolonged labor or postpartum hemorrhage, sepsis due to minimal laceration or multiple laceration, or improper sepsis. Anesthetic hazard or delayed or long-term sequelae, chronic low back pain, gentle collapse, especially if applied in incompletely dilated cervix, fetal asphyxia, trauma, mainly intracranial hemorrhage, cephal hematoma, facial or brachial palsy, and lastly, remote cerebral palsy, and fetal death around 2%. What about intracranial hemorrhage? Incidence nearly 1 in 300 cases failed vacuum extraction forceps followed by cesarean section. But 1 in 800 cases after vacuum extraction succeeded, and 1 in 600 after succeeded forceps, and 1 in 1,000 and 900 after cesarean section during labor, and the same figure with normal spontaneous vaginal delivery. Sure, less incidence occur after cesarean section without labor, about 1 in 3,000 cases in elective cesarean section. Pre-request for instant delivery, we can either words of forceps, polydilated cervix, 1/5 or nil bulb abdominally, rupture membrane, contraction present, empty bladder, presentation and position known, satisfactory analgesia and bitter anesthesia. This is the picture clarify how can be received by feeling PV examination. You feel that the head is very low, but actually the head is high. This can identified by abdominal palpation because here scaput and molding deceive us as the presenting part is low, but if we applied abdominal examination, we found that more than half of the head above symphysis pubis, so it's not engaged head. What about predictive of failure? If more than fifth of the bulb good station 0, except to posterior position, if there is excessive molding plus 2 plus 3 or through progress of big baby or obese women. Example of error which may lead to complication, abdominal palpation not done, so it should be done to make sure that the head is well engaged or plus 2 plus 3. Prolonged traction, continuous traction, rotation during contraction. Traction only during contraction. Should tract only during contraction. During contraction, you should stop traction. Traction direct forward and upward too soon. So you should downward. Then if the head about to distend the vulva, like normally, you should extend the head and change your direction of traction to upward or forward. The goal of the obstetric care is the healthiest possible outcome for the mother or the baby should not change it under any circumstances.